a metastatic kidney cancer patient. Work-wise, I work at the Brussels office of a communication and advocacy consultancy named LIDER. And on a more, let's say, international level, I'm on the board of the International Kidney Cancer Coalition. Today, I will do this presentation with a colleague of yours, Dr. Jewett, Professor of Surgery, Urology at Princess Margaret Cancer Center, University of Toronto, and Chair of the International Kidney Cancer Coalition, who will speak right after me. We will talk about the value proposition for engaging patients, the patient's voice in uro-oncology. Our association, what do we do? The usual patients association stuff. I will not bore you with that. You can imagine we do advocacy. Sorry, I just need one moment help with the slide because it's not moving. Non è sincronizzato. Quando io faccio così, rimane... Devo far così?
Allora, aspetta, lasciamo, riprendiamo da capo, scusi. No, perché è uscita da... Provi adesso?
No.
Sì.
No, le note rimangono...
Ah,
vedi.
ok.
Non so. Sì.
Le note non seguono le slide.
Ok, facciamo un secondo. Si vede così dove
Ok, è sempre con questo.
Sì.
Okay, so we do the usual patients association stuff. We do advocacy. We help patients. We do a lot of outreach. We run online communities. We respond to the phone and emails. So there is a constant interaction between our organization and patients, and we do awareness via campaigns, media relation, and so on. So let's get right into what we noticed in our daily interaction with patients backed by evidence. This insight is based on a survey presented by Dr. Van Melik, where patients were asked if they wanted to be part of shared decision-making for their treatment decision, and 90% of them said yes. However, we noticed that there is a gap between what patients want and what actually happens in practice when it comes to be involved in shared decision-making. And this, we can see it from this figure from the 2022 International Kidney Cancer Global Survey, which collected more than 2,000 responses across 39 countries from kidney cancer patients, and the data indicates that more than half of respondents were not involved as much as they wanted in developing their treatment plan in the area of shared decision-making. So we often see that doctors think they're doing a good job while patients feel differently. And many times we see the doctor operates under the assumption of what's important to patients, but this might not be necessarily accurate. We see a lot of patients getting information on their healthcare situation from patients' association instead of their healthcare team. And when it comes about true informed consent, that's usually missing in action. This survey also asked about the extent to which emotional aspects impacted their well-being since their diagnosis. And the majority of respondents said that they suffer from general anxiety and disease-related anxiety. And here the link between anxiety and shared decision-making becomes crucial because involving patients in their their treatment decision can contribute significantly to addressing the emotional needs of patients. Because patients regain a sense of control, of understanding and partnership with their doctors, contributing to their emotional well-being. Difficulty navigating the healthcare system, this is a big one. We see more than half of respondents highlighting challenges in this area and adding, of course, an additional layer of stress to an already very stressful situation. And And this is what I see daily with my dad. Many times the pain that patients suffer is exacerbated by how the healthcare system works. Poor communication, lack of empathy, and trying to get the responses from doctor can be very, very challenging for patients. Just an example, in Italy, cancer patients receive their CT scan report full of medical terminology via PDF autonomously without any professional interpretation. And it can happen that for weeks they cannot have a medical explanation from their oncology team. And this translates into sleepless night in which patients are asking themselves, am I dying? Am I not? Can I afford to not know for weeks? This is unacceptable. This is very heartbreaking to witness and to live in first account. Support from healthcare professionals. So from this survey, only 36% said that their doctor or healthcare professional was very helpful when discussing their concerns. And what we see is that a lot of pain is caused by this, and patients feel abandoned. They feel alone in a battle that is already very painful on itself. And the communication with doctor is often sterile, comprising protocols and devoid of empathy and communication. And often clinicians fail to grasp the gravity of this issue in clinical practice. So all this data shows a big problem, and what we just talked about emphasizes the need from a shift from a paternalistic model to a collaborative approach. Patients are smart. Patients want to be involved in the decision making. And not only we see that the health community has a one-way transmission to the patients of instructions and so on, but when they are designing research and establishing research priorities, they rarely engage patients in what's important. And this is just another example of a whole paradigm of delivery of healthcare that should be transformed. And this is where shared decision-making comes into the picture. It's a joint process in which healthcare professionals work together with the patient to reach a decision about their care. It involves choosing tests and treatment based on both evidence, of course, but also the personal individual preferences, beliefs, and values of patients. And it makes sure that patients understand the risk, the benefits, and the possible consequences of different options through discussions. And this, of course, improves the quality of care and contributes to a real patient-centric approach in the healthcare system. And there are advantages, of course. There are advantages also for the clinician themselves, because it reduces doubt and minimizes the likelihood of post-decision regrets, reduces unnecessary intervention and treatments, leads to more cost-effective healthcare, but also minimizes the financial burden on both patient and healthcare system. Patients are less likely to end up in the emergency department, their length of stay is shorter, and so on. And of course, it increases patient satisfaction, compliance. If patients know what's happening, they are more likely to follow instructions. And the fact that they are informed, they are less likely to be satisfied with the care provided, which means less medical legal action. And there are multiple papers about the benefits of shared decision-making as an important driver of quality. So, to conclude, physicians should become conscious about their limited application of shared decision-making in daily practice. As we said, this is a very helpful tool, and Dr. Jewett, right after me, will talk about it. And we know that for effective healthcare providers should collaborate with patients in equal partnership, respecting their point of view and preferences when developing treatment and as well as designing clinical trials. So we need you in this room to help us achieve this paradigm shift where patient centricity is not a buzzword anymore. Thank you. And now I will leave the floor to your colleague, Professor Michael Jewett.
I guess you can hear me okay? Just wave your hand. Yeah, good. I'm speaking to all of you from Toronto, and it's a great honor to support this very excellent presentation by Claudia. She's an example of the kind of people that pick up the advocacy banner, and in Italy, she is really an outstanding individual, and it makes me realize why I became involved in patient advocacy as a clinician over the years, to take advantage of my patients' experiences and perceptions. I'm going to just share with you some slides here. Your patients, all patients in their care. This is not a new concept. This has emerged over 40 plus years. Really, the common reference to this is one of the Institute of Medicine publications over 20 years ago that started the terminology of patient-centered care, or patient-centeredness, that is self-explanatory and I know is part of your care system as well. But I think as clinicians, and I speak as a clinician as well as an advocate, don't necessarily take full advantage of this to improve our quality of care, our outcomes and cost, our time management, and so on. It was about 10 years later that the concept of quality was linked to patient centricity, that by engaging the patient, its outcome, the outcome of healthcare, which is our number one priority and the reason you are retreating today from the daily activity of your center, is to think about the future. And this is certainly a key component of it. So there are many coalitions and networks emerging around the world where national groups get together, whether it be in kidney cancer, prostate cancer, bladder cancer, and these coalitions are now working together, networks of networks, if you will, and Europe is leading this, in my opinion, and the EU has been particularly supportive, but our payers at national levels and our insurance don't necessarily fund or recognize the importance of it, which is one of my missions, to try and get this as part of delivery of healthcare. So IKCC, the International Kidney Cancer Coalition, which I have the privilege of leading at the present time as the chair of the board, with the CEO, Rachel Giles, based in Amsterdam, who many of you know, I think. We do a number of things, some publicity around our World Cancer Day. We bring together affiliates every year for an annual Congress to talk about issues that they face. We are very active in trying to get advocates like Claudia into guideline groups. Rachel represents the kidney panel advocacy portion at the EAU, and the recent updates in kidney cancer guideline includes her input. A number of very interesting tools to help with what Claudia was talking about in decision aids. If you go to the IKCC website, you'll see these very interesting infographics that you can use in lectures to represent the landmark pivotal clinical trials as they relate to kidney cancer that are very understandable to patients, and in fact summarize it in ways that as clinicians we don't always think about it. It's a shortcut to a summary to present in your talks. What she's focused on, shared decision making, is extremely topical, and there is a great deal of interest amongst industry partners as well as payers to improve this. And unfortunately, the clinicians, in my experience, myself included, seem to see these kind of aids or tools as more time having to be spent. Whereas in fact, I think by working smarter, we can actually reduce the time that we spend with much better outcomes for the patients by incorporating advocates in our system, by information sessions before coming to the clinic, particularly in centers like San Raffaele, where you have critical mass and expertise that you can bring patients together separately from their clinical interaction with you, the clinician, for example. So we've built a number of decision aids which are available online, and there are many of these, I'm sure, in your own institution. Italy has been very active. This is a manuscript that was published a couple of years ago, looking at patient engagement in healthcare, and particularly right in your town here, Milan, you have local expertise, particularly at the Catholic University. What struck me in this field and really made me rethink how I needed to pay attention to advocacy was this research letter in JAMA now almost 6 years ago, 6 years ago, showing outcomes of patients with metastatic cancer. This was a clinical trial and a secondary outcome. This is an overall survival Kaplan-Meier curve, which you're all very familiar with. And basically half the patients were given access to nurse specialists 24/7, basically, to report toxicity. They were educated in the side effects of their therapy, and the result, as you can see here, was at least a 10% overall survival advantage to those patients that were engaged in their care. So this is analogous to a blockbuster drug that gets regulatory approval from EMA, and I featured this in a talk last year at the EAU in Amsterdam, the one before your meeting in March, and it was in July 22, and built out this hypothesis, and it was very well received by the urologic community. So we've already heard about some of the outcomes of successful shared decision making, and the qualitative outcomes I think are well known and well demonstrated. What's less well evidence-based is this issue of overall survival and other survival endpoints, which resonate with the clinician perhaps more than the qualitative outcomes. So I'll end with an initiative that I thought was successful enough to repeat. We're going to do it at ASCO GU in January again. We ran a reduced version at the EAU Congress in March in your town in Milano. And this is a clinician leadership workshop that is a day and a half of syllabus, if you will, with modules that cover the range of activities that we can engage our patients in, from being on research ethics boards to data monitoring to improving accrual to clinical trials, setting research priorities, designing better patient-reported outcomes, which are so critical now in clinical trials for good reason, and many other aspects of health literacy and, of course, decision-making. So we're going to continue to run these in the foreseeable future, and I urge you in your reflections at a retreat on how to make urologic oncology better at San Raffaele and elsewhere to incorporate the patient in those activities, people like Claudia, who bring a lot to our clinical table to improve our outcomes. So I won't go through this in the interest of time. One thing that's happening in Europe is this new updated strategy for cancer care in Europe that's called Time to Accelerate, and that was released in the last few days, and the IKCC is a signator to that. So thank you very much for allowing me a few minutes on the podium to beat the drum that makes my heart beat faster these days, namely the value proposition for engaging our patients in this case, urologic oncology. Thank you very much.
Virtual. So we'll start with Shilpa, who will replace Ashish Kamath. Unfortunately, due to flight issues, he was unable to come. But Shilpa is, of course, a friend of us, and I'm very proud to have her joining this year retreat. She's from Cleveland Clinic. She's chair and head of multiple clinical trials in geospace, primarily in bladder cancer. She's a very good friend. So Shilpa will provide you with the snapshot of the activities that are ongoing within the IBCG, the International Bladder Cancer Group, and the International Bladder.
Here, Andrea, great meeting. Obviously, I'm not Ashish Kamath, I'm just speaking on behalf of him. I will make it brief. So this is basically talking about two huge organizations, of which Ashish, as you can see, is the past president of International Bladder Cancer Network and current president of International Bladder Cancer Group. So the mission of IBCN is to improve the diagnosis, prevention, and treatment of bladder cancer through the application of biologic markers. Even here is also a member of that. And of IBCG is basically to improve outcomes through evidence-based treatment and practical educational tools applicable to the global society. And it's a multidisciplinary team across urology, medical oncology, radiation oncologists, basic scientists, pathologists, and really global in nature. As you can see, all continents are represented in both these organizations. So let's talk about IBCN. The current board members are all listed here. I'm sure they will consider a woman member at some point, but these are all prolific people from around the world. Ashish was the past president, and this is really a great meeting. Lars here had hosted this back in 2019 in Denmark, which was my last IBC, and it was really beautiful. I think this is the picture from there. This is the official IBCN publication, Urologic Oncology seminars, and all high impact work comes through this, as you can see here. The impact of some of the big articles that have come through are assessing the quality of studies on the diagnostic accuracy of tumor markers, led by Peter Gebel, consideration of urine markers in the management of patients with high-grade NMIBC, lead author was Ashish, and prognostic markers in T3 bladder cancer, again, senior author Colin Dinney, Gang Wong was the first author. Now, talking about International Bladder Cancer Group, the membership has really grown. It is a bigger group now, and I'm really honored to be part of this group as well, along with all these prolific people across the board. There's also a health science research arm of this IBCG, where collaborative source for global clinicians and researchers to improve population health, and this is led by Stephen Williams. And the IBCG is now also actively working together with Global Society of Rare Geotumors, led by Dr. Phil Spies and Andrea Necki here. So really coming together of the best of both the worlds to improve care globally. And this is just, the evolution of certain important work done by IBCG. For many of you who already know that the intermediate risk of NMIBC was first defined by the IBCG, and that's what FDA actually accepted as valid endpoints based on the paper that came out in the JCO on definitions and endpoints based on consensus meeting. And again, it's also in this is the article that came out this year in conjunction with SITC, or Society of Immunotherapy for Cancer, working together with IBCG on developing guidelines for bladder cancer across the stages. And in 2023, we just had a retreat 2 months ago in Ashish's hometown at MD Anderson, where we tackled the topic of non-muscle invasive bladder cancer and bladder sparing, and those papers are currently being written. So some of the key publications are shown here. I'm sure all of you are already familiar with these. And FDA has accepted this as a very valid source. Also, some work being done in the COVID-19 era on the potential use of BCG as a defense against SARS-CoV-2. Again, Ashish has been involved in this. And in the AUA Bladder Cancer Forum, there were very exciting debates on controversial topics through IBCG as well. So there are all these annual meetings and regional meetings that are organized and really open to all who want to join. A lot of collaborative projects from bench to bedside, and as well as IBCG registry and virtual tissue-based studies are ongoing. A key highlight for the IBCG was back in April 2023, and I was honored to be a part of this team, where we went to Chile on invitation to help them develop bladder cancer guidelines, which were very sparse at the time, and we helped them develop guidelines according to the resources available there and how it would be practical, because every country has different needs and resources. And we also developed the metastatic bladder cancer guidelines there based on the drugs availability there, and we found out that they were proposed and accepted by the Chilean Ministry of Health. So this was really a huge accomplishment for the IBCG team. And like I mentioned, in August, we had a retreat, and a lot of you in the room were present there, including Dr. Necki, Dr. Spies, who could not attend, but all of you were there. I know a lot of urologists, pathologists, and radiation oncologists were there. And that's the end of this, and I'm sure Ashish would approve.
Very insightful.
Johan Loriot from Paris. Updates from GETUG.
Johan is one of the founders of the original team of the retreat, so he's part of the original core business of the retreat. Please.
Maybe you can add in your introduction that I'm the only one Novembre guy, so maybe you should change something next year. I think.
What is this?
Yes. So thank to give you maybe to provide you the philosophy of the GETUG if you are not familiar with the GETUG. So it's a clinical research group in France. So it's got a 60 center, more than 100 active investigators. It's a group, and we have a sponsor, mainly Unicancer. And we have different funding from the Ministry of Research, from charities, from industry, and we try to collaborate with many other groups, SOGUG, IRCCS, SAC, and many other. So we try to be a multidisciplinary group, so we included, of course, medical oncologists, radiotherapists, urologists, pathologists, statisticians, and translational scientists. It's open to all. So I mean, public, for those who are from the public practice, for the private practice. And we have a steering committee elected for 5 years, and Karim Fizazi is the president elected. So GETUG is doing clinical trial with Unicancer as sponsor, but other hospitals can sponsor the trial. And as I said, we have a lot of collaboration with the pharma that try to fund some of the trials that we are conducting. A lot of collaboration are set in Europe, of course, but also worldwide to conduct clinical trial, to share data. And the strategy of the GETUG is to try to develop practice-changing phase trial, easy to implement, so mainly pragmatic trial in rare tumors, and we try to do some valorization of past clinical trial. So first of all, the phase 3, historically we have a large portfolio in prostate cancer in different settings, localized, intermediate risk, high risk, newly diagnosed metastatic prostate cancer, as you can see here. And we try now to expand to other frequent tumors, so mainly bladder cancer and kidney cancer. As you can see here, we conduct recently the VESPER trial, some trial in kidney, of course. And what we learned from this experience that we need collaboration, of course, between medical oncologists, urologists, and radio-oncologists. And frequent situations mean success, accrual success, and it is very critical, of course, for academic trial. We try to develop trial in rare tumor as well. So here's some example with the GETUG-13 trial reported 10 years ago, or in seminoma with the SEMITEP trial that we report last year. In kidney cancer, we try to conduct a trial in, for example, collecting duct carcinoma or in papillary tumors. And again, it's more challenging here for the academic group because rare situations are challenging. You need at most 10 years for accrual patient in GETUG-13, for example, in testis cancer. And the centralization of care so is key if you want to conduct some clinical trial in your country or in Europe, for example. Very recently, we tried to develop some proof of concept trial. For example, in bladder cancer, we report the PANDOR trial. We assessed pembrolizumab neoadjuvant in MIBC, and we did a lot of translational study to show that actually the intratumoral infections activate immune system and is associated with response to pembrolizumab in bladder cancer. There was also this trial, the BIONIC trial in kidney cancer, which was one of the first conducting a precision medicine trial in first-line metastatic kidney cancer. And last point is to try to do valorization of past clinical trials. So how to do data sharing. So for example, we share the data from GETUG-15 and GETUG-12 for the ICECAP project conducted by Chris Sweeney when he was at the Dana-Farber Institute. In prostate cancer also, we try to share the data from the GETUG-17 to do the artistic meta-analysis. And again, there is a lot of projects with the GETUG-15, the GETUG-16, again, to do some meta-analysis in Europe or worldwide. But one of the most important issues that we are facing when we conduct academic trial is that a large number of patients is likely to be needed to address important questions in the future. So for the phase 3 trial, national group is likely to be unable to make it, maybe except UK with Stampede. So we need for a pragmatic transnational system to be able to conduct such large trials. That's why we conduct the PEACE program, so the PEACE for Prostate Cancer Consortium in Europe. The principle is to do academic European trial, phase 3 trial, and the sponsor could be any academic group, so it could be a group, an hospital, a university. The budget is provided trial by trial. There is a chair and a sponsor. And there is a clear publication rule, and everything is described in this position paper reported in European Urology. So the first experiment was the PEACE 1, so conducted in Europe, in a lot of countries here in Europe, in France, Spain, Italy, Ireland, Switzerland. So we reported this data. Karim reported last year, and this year we report the second question of this trial, the role of prostate radiation at ASCO. And now we are moving forward with the translational study with different aims, genomic analysis, phenotype analysis, germline analysis, and transcriptomic analysis. There is a lot of new trials, so like the PEACE 2 trial in high-risk prostate cancer that address the question of cabazitaxel combined with ADT and the role of pelvic radiation in these tumors. Again, transnational trial in Spain, in Italy, in France, in Belgium. GETUG is collaborating with IRCCS for the PIS 3 trial that you are aware of, I'm pretty sure. And another example is a PIS 4 in metastatic castration-resistant prostate cancer that address the question of the role of aspirin or statin in this patient. Maybe we can improve overall survival. There is some rationale. Very recently, we designed a large program in patients with newly diagnosed metastatic prostate cancer, trying to address different questions in this patient. So, for example, for the oligometastatic patient, there is a trial called presso trial that addresses the question of radiation of the metastasis in this patient. There is also a trial in unfit patients, so-called the vulnerable trial, that addresses the question of the role of darolutamide in these patients. And very recently, we plan to open 2 new trials, the good responder trial. So Niraj describes this trial conducted by IRCCS, the de-escalate trial. And for the patient with poor response to the induction hormonotherapy, there is also a trial called GETUG 42 that addresses the question of the role of PSMA mutation for the patient who do not achieve good response based on PSA at 6 to 8 months. Some new trial, the PIS 7, again here in high-risk prostate cancer, 2 different questions, the role of boost radiotherapy on the prostate and the role of darolutamide combined with ADT, again in patients with high-risk prostate cancer. And the PIS 8 that address the role of radiations to metastasis for the patient with oligometastatic castration-resistant prostate cancer, and we are able to start off this trial in these coming weeks. We tried to conduct a lot of trials in prostate cancer, but also in bladder cancer. So you are aware of this trial, the VESPER trial, reported last year and reported in GCO. So I described this trial, the Pandore trial, so the French Pure 01 trial, I would say. So very recently during ESMO, we reported this trial, the NEMIO trial, that address the question, the role of immunotherapy, so durvalumab or durvalumab-tremelimumab combined with dose-dense MVAC in MIBC. So I think you have seen this data reported by Constance Thibault during ESMO. And we have some trials. So I think the most important in our portfolio, I would say, is the ALBAN study in high-risk non-muscle invasive bladder cancer that address the question, the role of atezolizumab IV combined with BCG in this population of patients. The accrual is completed, so we hope to do the first analysis next year. So again, it was a European trial conducted in France mainly, but also in Belgium, in Spain. Unfortunately, we cannot open any site in Germany due to too many administrative hurdles. There is also another trial, the INDUCT trial in upper tract disease, which raises the question and addresses the question of the role of immunotherapy combined to either cisplatin combined with Gemzar or the carboplatin combined to Gemzar. And we are planning to do a phase 3 trial as well. A lot of other trials that the bladder art study, which assess the role of adjuvant radiotherapy in MIBC, a phase 2 trial, as you can see here. Another trial is the bladder sparing trial. It's a trial that assesses the maintenance therapy with atezolizumab after the chemoradiotherapy for patients treated with MIBC. So trial in prostate cancer, trial in bladder cancer, in testis cancer, but also in kidney cancer. And I think the most important trial that now we are developing, the CARE1 trial, conducted by my colleague and friend Laurence Albiges, who developed a pragmatic trial. So in first-line metastatic kidney cancer, if the patient has a PD-L1 positive tumors, the question is to assess whether in a doublet immunotherapy is better than a combination of TKI plus immunotherapy. And in patients with low PD-L1 expression, the same question is addressed just to assess whether we need a PDL1 expression in this patient in daily practice. So the vision of the JTUG, of academic research, the main goal of academic research is to test new ideas, new concepts. So we have to go fast at reduced cost without too much bureaucracy. That's the main challenge that we have. Drug development is mainly trials sponsored by pharmaceutical companies, of course, which is critical for patients. But new strategy, new combination, exploration of different population of patients with rare tumors is mainly the art of the academic trial. And also, it's very important to be aware that academic research is a way to develop the creativity, and especially from the young investigator. Thank you.
Thank you, Johan. Otherwise, thank you. Thank you very much.
Now to move to the talk by Noel Clark from probably is from remote, yeah.
Yes, I'm coming remotely, and thank you for the invitation to attend once again your meeting in Milan. It's a real pleasure. Now, if I can you see my slides? Yes, you can see my slides.
Yep. Yeah, you can go. Thanks.
Screen there. Can the camera be adjusted so that I can pick it up and we can drive it from there?
I didn't realize what is the issue now. So are you able to proceed with your slides as they are currently? We see your slides very well.
I can't make the slides do anything, unfortunately. I must apologize for this, but I can't get the slides to move at all.
On the monthly basis, so he knows everything basically. I will leave you the words, and you have plenty of time to deal with the society. Please.
Thank you so much. My family's starting to wonder if I like to live in Milan more than Tampa Bay, to be totally honest with you. It's always a privilege. Congratulations, exceptional meeting. I think the quality of this really shows, number one, of the incredible talents in this department, but also it's also wonderful to see a lot of my great friends. So congratulations on an exceptional conference. So I'm going to go through the first few slides really quickly. I know we want to catch up on time, but the Global Society of Rare Jew Tumors, as Andrea and I often talk about, was our COVID project. As COVID started, we realized that both of us had a lot of interest and focus in rare cancers. A lot of our collaborations were focused, and we addressed and we identified several major issues. Unmet needs. Many parts of the world are not represented in many initiatives related to rare cancers. Number two, significant unfunding or lack of funding there is, and I think also developing a global group of people that are dedicated with strong patient advocates, as we were discussing earlier, no question is critical. So my disclosures, I do serve on the NCCN. I serve on the board of directors of the NCCN, but none of that has any relevance to what I was speaking about, and I have the privilege to working with my partner in crime as the president of the Global Society of Rare Jew Tumors. So again, from a historical perspective, I talked about this last year. And again, quickly, this is something we've done over the past 3 years, and I'm always astonished to see all the people that we've sort of approached to want to engage and focus in rare Jew cancers were on board, and everyone sort of took this. And I think about people like Shilpa, that's here, who's taken on the importance of getting funding in this area. Clearly, this is an area that doesn't necessarily get a lot of attention. Something we've learned from Jeff back there as well is that we have to start thinking a little bit differently about rare cancers. And not only about the histology, it's about what's happening at the genomic level. What is unique about these tumors? Jeff has strongly has his osmotic effect on us to really start looking at these tumors in a very different way that we have as clinicians. And really, I think what we saw early on in our experience is that the first global summit, which was on penile and testicular cancer, had over 500 guests, people across the world, really identified that there is a huge need and purpose for our society in terms of what we want to do. So organizational structure, this slide gets a little more complicated all the time. Shilpa mentioned this. One thing we're very excited about is this collaboration between the Global Society of Rare Jew Tumors and the IBCG. Really, we have a meeting that we're planning in March, which will be in Tampa, really focus on variant histologies. And I think something we've been talking about is we have to start thinking about variant histologies of bladder, kidney, and other cancers a little bit differently. Are the endpoints that we sort of have in trials the ones that are of relevance? Have we identified and characterized these tumors, number two? And there's really a huge need at the level of the FDA and similarly at other global levels to really start recognizing that these are unique tumors that need to be looked at a little bit differently. In terms of our leadership council, the great Petros, who I'm very fortunate I'm speaking before him, because or else he'd speak the thunder by doing his Greek dances and charming all of you, so I'm pleased I'm able to speak before him. But really identifying again that our society is really focused and dedicated to this. Although people always associate rare cancers as penile and testicular cancer, as we were just discussing, it goes far beyond that. I think a lot of our efforts have been really looking at variant histologies, and we'll talk a little bit about what we've done in the past, I would say 12 to 18 months. Really excited. We have a lot of really strong initiatives going on right now in sarcomatoid histology, kidney cancer, plasmacytoid, bladder cancer, in adrenal tumors, and importantly as well, related to answering really unmet needs. When I think about things, for example, like adrenocortical carcinomas, think about penile cancers that are resistant to chemotherapy, there really is no literature on there. And lo and behold, this publication, which I have to give the credit to Guru Sampavde and Andrea Apollo, who took this on as an initiative. This was presented at ASCO GU last year as looking at the safety, efficacy of immune checkpoint inhibitors in advanced penile cancer. There's really no literature on this. If you look at what is out there prior to this paper, it's really anecdotal, small surgical series. And this, lo and behold, was something that was just published in JNCI just a couple of months ago. And similarly, we have other initiatives in urethral cancer and extramedullary patch disease that will have similar opportunities and highlights. I think I just want to go this briefly. The meeting that we're, and the initiative that we have between our partnership with the IBCG is really one focus again on variant histologies of tumors. I know last time I was here, we had a lot of conversation on sarcomatoid renal cell carcinomas. We all know these are very challenging tumors. I think as surgeons and the medical oncologists, we talk about this. We clearly know IO is somewhat effective in some of these treatments, but all of us, we question what's the appropriate treatment paradigm. Is it surgery first? Is it IO first? Is it combination treatment? How do you manage a recurrence? The same rules apply in terms of some of the prognostic factors, in terms of which intervention you should do. Are those clearly things that we need to look at, again, in a different perspective? Something we're very excited about is our educational committee. I will say one of the things we've realized, again, we have great expertise in centers such as this and other institutions across the globe. But one of the fundamental challenges when you go to certain parts of the world is establishing the diagnosis of a variant histology or of a rare cancer is quite challenging. So a lot of our educational needs and efforts have really been focused in educating healthcare providers, patient advocates, to improve ultimately the level of knowledge, education, doing journal clubs, making sure people understand the state-of-the-art, best quality of care out there. And no question, this group has been very successful in doing journal clubs and really focusing our educational opportunities across social media and various other venues, including our website, which is live at this point. The educational committee has really developed, again, a platform of various opportunities and educational efforts. I think these are clearly things that we're going to continue to expand. I always look at the bright young people in this room. Andrea and I always sort of say we're always interested in having young people and talented people work with us. And this is really what I refer to as a grassroots effort. The young people are the future, and clearly these are opportunities to not only advance the field, but advance your careers as well. In terms of educational activities and preparation, I think something we're very excited about is some opportunities we have in developing podcasts. We've had some good conversations with Backtable. Backtable is a podcast series. I did it several years ago on penile cancer, but the group from Backtable has approached us to do a series on rare cancers, and this is something which I think Andrea will be launching in the next couple of months, and it'll sort of be focused on various topics, so I'm very excited about that opportunity and that initiative. In terms of genomics research, Roger Lee, who I'm very privileged is one of my young partners of my institution, is very focused, and he's really collaborated with Jeff and the team from Foundation Medicine to do multi-omic type research. We sort of had their efforts specifically focused initially on CDH1 mutated tumors and plasmacytoids, and really I think this is clearly something which is bearing fruit in terms of help identify, recognize that these tumors are quite unique, but may identify some unique actionable mutations which could be targeted. In terms of some of the meetings we've sort of had our efforts and successes at, EAU 2023, US CAP, ASCO 2023, we have several publications. We've had privilege to publish in several journals. I know we have a paper currently in submission, really focusing and taking a step back, because I think as a scientific community, as we're sort of talking about today, we have to look at rare G tumors a little bit differently. Again, not based solely on incidence in our healthcare systems, but across the globe, and taking into account the trials that are available to patients, the advocacy efforts that are available to patients, make sure we have a more holistic approach to make sure everyone has access to these treatments and these trials. And I think some of the work in plasmacytoid is very exciting, and I think I'm looking forward. We talked a little bit about this earlier. Jeff is definitely a bolt of energy gathering a lot of us that are dedicated to this space, but I think there definitely is some huge opportunities using some of the wealth of resources available through Foundation Medicine, which Jeff has facilitated for us. In terms of other efforts, our pathology subcommittee has been done a great job, led by Lara Harrick from Emory University, but Hikmat Al-Mahmadi, who many of you know, a very talented geopathologist at Memorial Sloan Kettering, has taken that on in terms of, again, leading these efforts. I think there are several webinars that he's organizing in the next coming months, in addition to some projects we're hoping to soon are engaged. And sort of talking again based on some of the other efforts we have in place, the Adrenal Committee has really been quite successful in helping develop great educational resources for clinicians seeing patients in the clinic, including what is the workup you should be doing for patients with adrenal masses, what is the best level of care for patients. Alex Kudikoff led that group for many years and has sort of passed the baton to Ben Ristow and doing some great work related to, again, advancing fundamental educational resources and clinical projects, including developing a retrospective large cohort of adrenocortical carcinomas and characterizing these tumors a little bit better. As we know, it's always a continual challenge in how we manage these patients. Planned projects that we have, again, beyond this space is clearly several-fold relating to developing clinical practice updates, doing a review on percutaneous biopsy, optimal strategies in terms of workup of pheochromocytomas, and definitely more to come from this committee and talented group. Last but certainly not least, I think the group is also focused now on sarcomas and looking at urethral tumors. We have a paper that's about to be published in BJUI looking and developing best level evidence in how we should manage and care for urethral carcinomas. I am always astonished. This is to give you an example for urethral cancers. There's only one paper that's ever looked at when you should do a lymph node dissection for patients with urethral cancer. People always apply penile cancer literature and saying, well, you should always do a lymph node dissection if patients have aggressive pathology. Well, the only single study that was published is based on a national comprehensive database study of 100 patients. That's it, that's all. Best level evidence is clearly very poor, and I think this, in addition to efforts we have, I think hopefully will elevate the quality of care for patients. Last but certainly not least, I think one of the great joy that I've had is to partner with my great friend and talent, Andrea Necchi. As all of you would know, Andrea, when you do something with him, he takes it here and takes it all the way to the end zone. So it's really something which has been, I would say, one of the highlights in my academic career is to work with such a talented, dedicated, and a wonderful friend such as Andrea. So thank you so much. And what's on the horizon is obviously clinical trials and more efforts in patient advocacy. So thanks so much. I wanted to keep it short and happy to answer any questions.
Mission, remember the efforts of trying to coagulate people from underrepresented countries in being embarked in common goals and studies in angio cancers. For example, there is Christian Agebo from Nigeria, virtually connected, attending the meeting from there in YouTube. And we are trying to coagulate more and more people from Africa, for example. So, what do you think?
Yeah, absolutely. I think, we have had really great engagement from places like India. Gagan Prakash and the group from Tata Memorial, as many of you know, is a very high volume institution in India. And we've had wonderful, I think, engagement from people within the COW in South America as well. But I think there's a huge unmet need, and we are very much engaged to engage people from South America, people from Africa, people from Australia clearly who may have opportunities to teach us a little bit about the differences in how they care for patients. What we often say is standard of care in Europe or North America is very much not the standard of care in other resources. I will say what I've learned from my efforts in the NCCN is, for example, when we look at guidelines in developing, for example, in parts of Africa, we need to understand cystectomy or neoadjuvant chemotherapy are not options. So we have to also understand that our guidelines may not be applicable, but that also provides opportunities to learn from others and provide best level evidence in terms of what we do in our country. So definitely, I think, continual efforts to engage colleagues from across the globe. We're always very interested. If you know of people that want to work and initiate in efforts like this from across the globe, we're always willing to engage them and involve them in various projects and initiatives.
Carlo, please. Shall we have a mic?
I have the mic.
Oh, Jeff. Would you like to make
my comment's very quick. Thinking out of the box like I've tried to do with the Global Society about various things, I came up with common genital urinary cancers in unusual locations, and just got my first ever young male with an undescended testis who finally was found to have a splenogonadal fusion where the missing testis had actually fused with the splenic onlaga and was contained within the spleen that developed a non-seminomatous germ cell tumor. So there was a rare situation where the histology was expected, the genomics was expected, but the location was extremely rare. So there's a lot of ways we can think about this.
You know, one of the perfect examples is Sarah Tsuka, who many of you know, reached out to us and said, I'm interested in understanding how testis cancer involves tumor thrombi, because obviously many of the surgeons in the room clearly have had a few of these cases where you have these whether it's teratoma, whether it's actual viable cancer that grows into vessels, but there's no series out there, and the truth of the matter is, as we know, a case report or a care series is essentially useless. So unless you're able to gather efforts from across the globe, from reputable centers where you have quality research, essentially we don't have the experience to share with others.
Carlo, please.
Well, the question is, what's the strategy to raise the money that's needed to do it, right? Because if it's rare, certainly the industry may be skeptical about to do it. The second thing is that when I was at GSK, I was talking to the head of GSK in China. I was responsible for rare diseases. And I was talking to him about rare diseases. He looked at me and said, in China, we can do lots of work because the rare disease in China is under 2,000 patients. So the question is where to go and look for actually the resources to do it.
So a great question, obviously one we've thought about long and hard. I will tell you, for variant histologies, I think that's clearly an area of focus of many industries and many of the companies, because obviously developing and designing trials will require a global community. And I think Andrea was, to give him credit, is the one who's brought that perspective. I think we have a lot of opportunity here to do these types of global trials in this space for certain variant histologies. But when you look at penile cancer, and I'll give you the personal example, I've been involved with the International Penile Cancer Advanced Trial now for 3.5 years, in charge of the Surgical Oversight Committee. We put 120 patients over 6 years. And to your point, is getting funding to do these studies is nearly impossible. But where I think our society has an opportunity is to take that on, engaging high volume centers across the globe. Obviously, it becomes challenging, as you well know better than I, to engage industry to do these type of global trials globally, but I do think it does provide an opportunity to be successful in accruals, because if we do it in North America or we do it in Europe in certain subsets, we're not going to be successful. And I think that's what I've learned, obviously, through my involvement in trials such as this.
We are also suggesting to the companies to thinking out of the box, and that with the broader lens, like, so if you consider, for example, the penile cancer is rare for us, small part of the world, but it's quite frequent in Brazil as compared to Europe. So the issue and the consideration regarding frequency of the certain tumors are conditioned by the way and the perspective that you take to look at this disease. So maybe also consideration to make when putting efforts and putting money on certain programs and certain initiatives. I think that should be a bit revised, and maybe, this is an effort that we should make as academic investigators, involving the companies to put the interest in certain path. But when dealing and when looking at things at a different perspective, right? Yeah.
Yeah, I'll tell you the last thing is that in order to convince the CEO of GSK to do a partnership with San Raffaele Hospital for rare diseases, the only strategy that did work was to emphasize the importance of advancement of the science and the technology that could then potentially be applied to a much larger population of patients. This is what we're doing right now. Try to take the science that was developing rare disease in oncology. That a way that probably a big pharmaceutical company would say, perhaps is
That's a good perspective.
What we did and we are doing in squamous cell tumor, for example. You can start from penile cancer dealing with squamous cell tumors and then enlarge your perspective to other squamous cells with more frequent disease types, of course.
You're right. I think that's an important question. I think that is, a unique opportunity for us, because we have that global identification of those centers that are clearly unique. You know, like you said, underrepresentation. You look at a place like Tata Memorial, their testis cancer and their penile cancer volumes are staggeringly high, but they haven't been able to publish. Part of that is they haven't been able to participate in some of these larger trial groups and studies. But they have good science and they obviously do quality care. But I think robustness of being able to participate in this, I think gives us opportunities to advance the field.
Thank you, Phil.
Thank you.
Thank you.
Italiano o inglese? In Italian. Italian, perfect, perfect. Or in French. Johan is this. I can talk in French, no problem.
Scusa?
Mille grazie, grazie mille. Oh, Dennis, yeah, a little bit of everything.
Okay.
Thank you so much, my good friend Andrea and the whole organizing committee. What a great opportunity to be here. Sono molto contento, grazie mille. I also was very happy to practice my Italian during my stay here, and what an honor to follow on the stage my good friend Philip, which actually his real name is Philippos, a Greek name. So thanks again for having me. I'll try to give you some examples about what we're doing in the ECOG Akron, which is one of the main cooperative groups in the United States, like SWOG, that Neeraj and Silpa are involved, Alliance, NRG. ECOG Akron is a major cooperative group, like GETUG in France and ERTC in Europe. And I'm just going to give some examples of the work we're doing there. These are my disclosures. In terms of the structure of the ECOG Akron, there are multiple different committees. And these committees are mainly divided by the cancer types, like disease groups, right? So breast, sarcoma, thoracic, GU, GI. And we also took the extra step with the leadership to develop specific subcommittees that take into account not only the organ of origin, the cancer, the traditional cancer type, but also the genomic biology of a biomarker of disease, and to develop committees and subcommittees that have to do with developmental therapeutics and development of new therapies, take into account the molecular biology, the biomarker and makeup of the tumors. That's where there was a development therapeutics committee and genomics committee, subcommittee that span across different tumor types and get away from the conventional tumor type specific approach to a more molecular based approach and design what we call basket type trials that span across different tumor types. So we have different mechanisms within the ECOG Akron Cooperative Group, and this is a slide that summarizes examples of those mechanisms to develop clinical trials. I'm going to spend a couple of minutes talking about the combo match trial, one huge initiative from the National Cancer Institute, which I have the honor and privilege to be part of, which is, as I will show you, a very important basket trial across solid tumors that is testing combination therapies, rational combinations based on preclinical data. ECOG Akron itself is running multiple trials, and I would argue many practice-changing trials that have come over the years across tumor types. And I will show you some examples of ongoing trials we're doing right now. And at the end, I'm going to give you an example of what PRECOG is doing. PRECOG is a clinical research associate, I would call it, like a clinical research office that is the liaison between companies, different pharmaceutical companies, and cancer centers, and is running the trial, the operations of the trials, and is contracting with the pharmaceutical industry sponsor and the cancer centers and try to make these trials operate well. I actually had the chance to work with them over the last 7 years, and we're very close to actually publish one of my investigator-initiated trials with neoadjuvant immunotherapy, a topic very close to Andrea's great work. So stay tuned for a paper coming soon in a great journal. European journal, I would say. So what is important, right? So what are the advantages of the collaboration? I think collaboration is a theme, is a key. And I will probably take the microphone because, I love to dance, as Philip said, so I can move around more freely here. So the advantages of collaboration are very, very important. And I always encourage young mentees, trainees, always seek mentorship and collaborations. So the talent involved in these cooperative groups is very important. Key opinion leaders and thought experts across the different fields, experience across studies and phases, phase 1, phase 2, phase 3. Mentoring, of course, is very important. We just talked about that in the previous talk by Phil and Andrea about mentoring in the global site of rare GU tumors. And of course, advice we can provide, in junior faculty and mentees and fellows in clinical development. We're doing quite a bit of that. Neeraj and Silpa, you're doing similar work in SWOG, and I think this is part of our mission to educate the next generation of people. And of course, the different cancer centers with a well-equipped mechanism and infrastructure, resources to conduct trials that can be practice-changing, but also going back to the previous talk that Phil gave, also paying attention to rare tumors, right? Because usually, to your point, Carlo, pharma companies not always start, right? Usually do not start with a lower incidence indication. They go to much more common indications. So paying attention to rare tumors is important. We try to do those trials. So in terms of the purpose of the trials we do, registration trials that go to regulatory approval by FDA, for example, or EMA in Europe, usually go through the ecocacrin or less commonly through the precog mechanism. Combo match, I will show you in a second, is mostly a signal-seeking study looking at, again, rational combinations that may have future, but it's not a registrational trial itself. International participation, which is relevant to our meeting here, is possible through the ecocacrin or precog, and I know, Andrea, we have talked about before how we can collaborate further in ecocacrin trials and involve international members, which I think will be fantastic in, again, the same concept of the global effort and the global collaboration. Now, I talked a little bit about combo mats, and I can tell you back almost 10 years ago, time flies, I was honored to be involved in the NCI MATS version 1. This was one of the first basket trials across solid tumors that aimed to characterize the safety and efficacy of single-agent targeted therapies in a basket trial design based on a molecular alteration, genomic alteration, that may be based on a tumor. And Jeff, you have done a great job in the field, transforming the field. So you define an alteration that may be a driver across tumor types. You can potentially evaluate the efficacy of those agents across tumor types, regardless of where the tumor originated from. The NCI MATS version 1 had about 30 or plus, more than 30 cohorts or arms, and there were many lessons learned. Many of those cohorts were published now, and some of them led to a bigger trial, signal-seeking trials in the MATS version 1. And obviously, because of the mechanism of resistance, as we know, many of those targeted therapies may work in some patients for a while, but usually resistance emerges. And evaluating the molecular landscape, as Jeff mentioned before, is very important because it can give us the opportunity to define resistance mechanisms. And as Lars and Iwan mentioned this morning, identifying these mechanisms of resistance in the tumor tissue and or ctDNA can be relevant to identify potential combination strategies. Taking that into account, combination match is looking for combination therapies, and any therapy counts is allowed except for immunotherapy. Immunotherapy has a separate trial called IMATS, or immunotherapy MATS, is led by SWOG, and combo MATS is focusing on pretty much non-immunotherapy trials, combinations, because again, multiple genomic drivers may coexist, co-occur across tumor types. And obviously, we want to look at safety, efficacy of combination therapies, and try to learn from those different experiments. There are different requirements for those combo mat studies, and again, I'm interested to see if a similar effort may be generated elsewhere. Really, I'm a member of the working group that evaluates proposals, the working group for genes and agents for this study. And what we're doing is we're looking for really robust rationale, combination of therapies that is based on really robust preclinical data that shows biological plausibility, that biologically this makes sense, and also there's some degree of in vivo activity of two drugs combined together based on genomically defined preclinical model, PDX, xenograft cell lines, and of course in vitro, but also in vivo, as I mentioned. Tolerability and safety of the combination is nice to have, but it's not mandatory because there can be a safety lead-in or a phase 1 study evaluating that component. And the potential eligible patients are identified by standard of care genomic testing. So patients may have had one of the commercially available platforms that Jeff talked about earlier today, or things that, Lars and Iwan mentioned, and all of those platforms can be identifying targets, and those patients can then be screened for the combo match trial. So there is no central biopsy done because of lack of funding, but we can use definitely validated, excellent commercial available platforms or academic platforms, right, in different universities that may be homegrown and developed. And I know, Andrea, you have assays in your institution here looking at genomic biomarkers. And obviously, we want to do biopsies at baseline and at the time of resistance, progression, to look at whole exome sequencing, RNA sequencing, and of course, looking at tumor tissue and circulating tumor DNA trying to evaluate potential resistance mechanisms, evaluate the concordance between tumor tissue and the peripheral blood. And again, this can be histology agnostic or can be part of any particular tumor type. Statisticians are very helpful in designing those trials. This is a schematic of how this works. Very quickly, a genomic alteration may be identified by an academic or commercial available platform. If the patient is having that genomic driver, it may be eligible for the studies being approached, consent is being signed, screening is done, the eligibility form is submitted to the NCI. The match box is not the black box, but the match box is performing this matching to make sure that each patient can match in a particular cohort. And I will show you there are multiple cassettes and cohorts arms in this study based on the molecular alteration. And obviously the patient is, if he or she is eligible, then is being enrolled in the study. There is treatment, or as I mentioned, biopsy, baseline biopsy progression to identify both with tumor tissue and liquid biopsies potential mechanisms of resistance. These are examples of ongoing cohorts that have gone through the working groups of genes and agents, and you look pretty much all these combinations that you see in that slide have gone through a series of different filters, committees, that actually scrutinize the data and say, okay, this looks good enough to go to a trial like this. So all these combinations have gone through a really very robust selection process and survived. So these actual trials are now up and running. As you see, there is accrual happening, and this is as of about 3 weeks ago. And I can tell you, all these 5 trials that I show you here are really based on very robust preclinical data, showing again biological plausibility and some potential synergies or at least additive effect in vitro and in vivo preclinical models. And there are many other concepts and ideas in development. You see here examples. I know neurologists have done so much work with PARP inhibition. So the third column here is olaparib plus alpelisib, a PI3K inhibitor for specifically breast cancer with DNA repair gene alterations. So you see that all of those cohorts are based on the presence of a molecular alteration that may drive the tumor behavior and tumor biology. So it's, as I show in this slide and in the next one, molecular alterations are important for selection. And there are multiple different examples of those molecular alterations that may be a target, and these targets, again, can be exploited, and different combinations can be proposed. So if ideas exist, feel free to talk to us. Again, international collaboration is not that easy in the combo mats, but maybe other opportunities through ECOCACRIN and PRECOG. Before I close my talk, I'm going to give you very quickly a few examples of real-world trials that we're working with in the bladder cancer subcommittee. Bladder cancer subcommittee is part of the GU committee. Mike Carducci is our committee chair for GU, and Noah Han, my good friend from Johns Hopkins, is the bladder cancer subcommittee chair. And I just want to give you some examples how we have trials across different therapy settings to try to address different questions and meet different needs across the spectrum of bladder cancer. So in the domain or the arena of non-muscle invasive bladder cancer, you see here we have an important trial called ECOCACRIN 8212. This is the so-called BRIDGE trial. Good friend Max Cates, a wonderful urologist from Johns Hopkins, is leading the trial. This is I would say in a high risk BCG-naive non-muscle invasive bladder cancer. Is comparing intravesical BCG to intravesical chemotherapy, gemcitabine and docetaxel intravesical delivered, try to see whether we can challenge the dogma. I think Umberto this morning talked us about challenging dogmas, and one of the dogmas is BCG-naive disease is that you have to give BCG in high risk and intermediate risk disease. The question is, can we get by with a different regimen, especially in the context of shortage of BCG that is important in the United States. So that trial is comparing intravesical chemotherapy with intravesical BCG. This trial started recently, but it's accruing very well, and kudos to the group that it moves this trial along. Another trial that I was discussing with Silpa earlier today, and I would love you to see this trial open, and Phil, maybe something for your site to open too, is the ECOCACRIN 8192. This is a upper tract trial. It's a neoadjuvant trial for patients with renal pelvis or ureter. Patients who are cisplatin eligible are being randomized to dose-dense MVAC with or without durvalumab, so chemotherapy alone, or chemoimmunotherapy, and we're actually very excited. This is a phase 3 trial. We're accruing very well, and also we have a separate cohort, cohort C. This is for cisplatin ineligible patients, and they're getting a combination of gemcitabine and durvalumab to see whether we can have some data in a phase 2 single-arm cohort in cisplatin ineligible patients. This is building nicely upon a previous ecocacrin trial, the 8141, that looked at about 30 patients with dose-dense MVAC and showed a pathological complete response rate of 14%. So we try to build upon that story to see whether chemoimmunotherapy can produce more results than chemotherapy. In bladder preservation, there are multiple trials going on. One of them is a collaboration among all the cooperative groups. SWOG and NRG are leading the trial, the S1806. This is a trial with concurrent chemotherapy radiation after a maximum to URBT, with or without atezolizumab. So the question we try to answer here is the addition of checkpoint inhibitor, anti-PD-L1, necessary or not? Does it add value to the backbone of chemoradiation after maximum to URBT? This trial is accruing very well, and I think we're going to finish accrual in the next few months. We're very excited. This was a titanic effort indeed to get all these groups working together. Another example of collaboration, that what we can do if we sit on the same table and we try to synergize, it's really, really excellent. And I'm honored to be part of both of those trials. I'm the co-chair of the previous trial, and I'm part of the correlative biomarker leading group in this one. And in metastatic disease, I don't want to leave alone the trial that Silpa has actually led and is still leading, a huge effort from the Alliance Group, and I am honored to be the champion of that trial from ecocacrin. The main CAF study, as Andrea mentioned elegantly this morning, the Javelin Bladder 100 trial, standard of care, I would say, in 2020 until, it's still, I would say, very important. They changed the paradigm with the switch maintenance avelumab, and Silpa and Alliance team is trying to build upon that, having different options. We have either avelumab monotherapy or avelumab plus cabozantinib in the switch maintenance setting, and this trial keeps accruing. This is for patients with disease control, response to stable disease after platinum-based chemotherapy. I think recently there's an amendment going on looking at changing the primary endpoint to progression-free survival to make it more feasible because probably slower accrual that may be impacted by the AV pembrolizumab data that Silpa mentioned. Before I go, very quickly to mention there is a lot of effort and discussion in ecocacrin for one topic that is really in my heart. This is a cancer screening using circulating tumor DNA. And Lars talked about ctDNA earlier today. I had the honor to be part of a NCI committee led by Dr. Monica Bertagnoli, who is now the director of the NIH. And Monica actually put us together and worked very hard to develop ideas and concepts of how we can design trials evaluating the clinical utility of what we call multi-cancer early detection assays, MCEDs. And I think it's very important to prove the value of those assays, because we know that there are actually data out there discussing the potential role of this DNA, but I think proving that it has value in terms of reducing advanced cancer or reducing mortality from cancer, I think is important. And we had a lot of discussions. We have a manuscript already published from the cooperative groups looking at cancer screening using ctDNA as a potential trial design, and there are ongoing trials right now looking at these questions. I think it's important to note that every time we do screening trials, right, even prostate cancer is a long process, so we have to do those trials also in the context of multi-cancer early detection to evaluate whether these assays are useful. And of course, a few departing thoughts, as you see here in this slide. Some of those thoughts have to do with the collaboration, the importance to utilize technology to detect minimal residual disease, as discussed earlier by Lars and Jeff. Obviously, the advantage of the cooperative groups is you have multiple cancer centers, you have expertise, you have multi-academic and community practices close to the real world across specialties, and these collaborations can be synergistic. Opportunities for database and registries exist. Biobanking, of course, similar to the question that Jeff asked Phil before, how can we use international national biobanking to harmonize the collection of biospecimens in a uniform fashion, so we can try to collect the things in the same manner, so to allow uniform testing down the road and validate biomarkers, and obviously think about ideas for germline testing, germline mutations, in addition to somatic testing. And of course, funding is always something we try to seek in order to achieve and materialize and complete those clinical trials. Thank you so much for having me here, Andrea and team. It's always an honor and opportunity. Mille grazie.
Thank you, Petros. Noel is able to connect and to go with his slides.
Okay, let's have another go. Can you see my slides?
Yeah.
Okay, that's a start, good start. Well, my apologies for the technical difficulties. I'm going to give you an update on the STAMPEDE trial. And I think most of you will be familiar with that. It was the world's first ever multi-arm, multi-stage, or what we call a platform trial. And that includes any type of multi-factor trial, including basket trials. And it's been running as of 2024 for 20 years. It's the world's biggest prostate cancer trial. And so I'm going to just remind you of what it looked like in its first inception here back in 2006 with the multi-arm, multi-stage. We actually started in 2004 with the planning and direction of this. And you can see that we've moved through a number of iterations of the STAMPEDE trial. We have linked it into hospital episode statistics at a national level now as of Jan 2018, and we've got that updated now for March 2021. And I'm going to show you just the power of harnessing multiple public health data with a big cancer trial like STAMPEDE. We read out the docetaxel arm, the abiraterone arm, the radiotherapy in the primary setting, and the combination therapies in those timescales. And we have currently recruited over 3,000 patients in the metformin arm and added in a cutaneous estrogen patch arm known as TE2, which will give us information on just how good estrogens are at avoiding some of the toxic complications of standard testosterone suppression. This is what STAMPEDE has achieved so far. And interestingly, when we were going through the data to plan the analysis for the metformin arm of the study, we found that we'd actually improved survival in the M1 prostate cancer patients for between 3 and 7 years, which is a really considerable achievement, I think. And that goes not only for STAMPEDE, but for all the other trials which have been closely associated with it. Here is what we have left to do. Let me go back. The metformin arm has 3,000 patients in it, and we have a translational element of that study, which is ongoing at the moment, which was looking to pick up serum samples with a number of international collaborators. And we're going through the process of pulling in the tissue, which we will use. You can see the sites that are involved in those collaborative ventures. We had, up at the height of STAMPEDE, 140 centres recruiting into the study. I'm going to talk about some of the translational aspects of science which we've hitched up to STAMPEDE and which have been running through 3 big groups. One is the Stratosphere group, which is looking at tissue and fluids. Another is the biomedical imaging group, the big group, looking at imaging, disease distribution, outcome, toxicity. And then a third group, PSMA, imaging, radiotherapy. And all of these individual groups are interlinked. They're not working in isolation. There's a complete triangulation of all the data, the imaging, the genetics, and so on. And you can see some examples of how that is coming to the fore with Decipher signaturing in M0 prostate cancer, the use of radiotherapy in upper tract obstruction, the incidence of fractures with long-term ADT, and so on. And we have a very healthy body of senior and junior researchers. This was at our last meeting about 3 or 4 months ago in London. And you can see that what we're trying to do is future-proof the trial So we have a combination of clinicians of various stripes, surgeons, radiotherapists, medical oncologists, pathologists, and so on, statisticians, and junior researchers coming through who ultimately will take over the trial for the next 10 to 15 years as it runs. This is some of the work which has been going on, collecting tissue from all of the sites around the country, centralizing them with a specific model of acquisition, data sampling, and genetic analysis, both in an academic sense, but also in combination with industry. This is one of the papers which we published recently from Emily Grist, who's the head junior researcher with Gert Attard leading that particular group, looking at the accumulation of copy number alterations with low-pass whole genome sequencing and clinical progression across the advanced prostate cancer landscape. And you can see the sort of genetic distribution and the interrelationship with outcome and treatment that we can now get from this STAMPEDE data set. This is the latest iteration, which we presented at ESMO in this year, in a collaboration looking at AI-based methodologies with Artera. And this is on a single biopsy core of a prostate tissue biopsy. So something that can be acquired from any urology department anywhere in the world, putting it through an AI program, looking at the influence of adverse prognostic factors in M0 disease and the adverse prognostic factors in M1 disease. And the purpose here is to try to identify those groups of patients who will need treatment intensification or modification of their treatment regimens, or equally importantly, to de-intensify treatment, to try to reduce some of the toxicities which we know happen with treatment. And if you look at the results of this is on an easily available resume of what was presented at ESMO. This is about to go probably into the Lancet. We can stratify M0 patients on the basis of their nodal status with N0s and N1s. We can then subdivide the N0s into a higher risk N0 group and a lower risk N0 group, and similarly with the M plus groups. And we can do the same with patients who are M1 high and M1 low, again, looking to intensify treatment where we can and de-intensify treatment where we don't need such a powerful and perhaps toxic regimen. And ultimately, it's hoped that we can put this straight into clinical use on a single prostate biopsy using an AI methodology. One of the successes that we've had in recent years is the development of the big project. And this is not a small undertaking. This involves centralizing all the images from patients going through the STAMPEDE trial and putting them on a central server so that they can be then analyzed for disease burden, imaging biomarkers, toxicity assessments, and so on. And all the imaging has to be brought in. It has to be de-anonymized. And then it has to be interrogated, labeled, and cross-correlated with the clinical data, both from the STAMPEDE secure data set and from the hospital episode statistics. And I'll show you the power of some of the things that go on. So this is how it works. We have a safe data haven down in the MRC Clinical Trials Unit based in London. We pull in the images through an imaging exchange portal. We then interpret the scans. And we feed the whole lot back into the data linkage, both with the UCL data safe haven and with publicly available hospital episode statistics. And you can see here, looking at arms in M1, comparisons AC to AJ, the number of scans that we've had received, bone scans, CT scans, and so on, looking at all the comparisons. And we're currently, we've accessed all the M0s, and we're currently in the process of bringing in all the metformin scans. We have about 85% of the 3,300 cohort, so this is quite a powerful imaging data set. We're looking to analyze these not only for bone metastasis burden, and we've already established that that's an important clinical parameter, and that has set the tone for high volume and low volume assessments. We've studied lymph node metastasis burden, something which has never been done before. We've looked at bone mineral density. I'll show you some data in a second. And we're analysing things such as sarcopenia, vascular risk, and so on. And this is the data set that we have built on using hospital episode statistics. And in a number of countries, these data banks exist. The Veterans Administration in the US is a good example. And we have what's called the National Prostate Cancer Audit, where we censor every prostate cancer diagnosed in England and Wales since 2013. And we did that on an annual basis, about 40 to 50,000 cases annually. And we're able to pull in data from all NHS data resources, such as through NHS Digital. And this is what we do. To give you an example, looking at the obstructive uropathy rate and the spinal cord compression rate, whenever a patient attends hospital for a procedure or has a diagnosis, there's a code applied, whatever that code is. And you can see all the diagnostic codes for upper tract intervention and obstruction, and all the codes for systemic progression. So we can get our patient, we know what treatment they've had, we know how they presented, we have their scans mapped, and we have subsequent interventions further down the line, often at 10 years and well beyond trial finish dates. So if we look at this, which is a good example of what you can do, this is the incidence of fracture-related hospitalizations in men with de novo metastatic and high-risk localized prostate cancer. We presented this at ESMO recently, and this is just about to be submitted again to the Lancet for publication. And these are the kind of numbers that we work with. So we had just under 3,000 patients randomized, linked cohorts in 2,000 for arms A, B, C, and E of Stampede, ADT plus zoledronic acid, docetaxel, and docetaxel and zoledronic acid. So good numbers to work with. And then when you cross-correlate that with the fracture rate, and remember, these are fractures requiring hospitalization. These are not just radiological fractures. What's interesting is this, that the fracture rate in M1 patients was 30%. But even more interesting, in M0 patients who were receiving ADT and radiotherapy to the primary, the fracture rate was 26% overall. And when we analyze that, looking at those patients who've had ADT alone and then added in zoledronic acid, what we can see is that there's a major reduction in the fracture rate. And if you look at the graphs on the bottom left of this, you can see that the cumulative incidence of fractures is roughly halved when zoledronic acid is added to the regimen in M1 disease. So that's an important consideration. Now, bear in mind, this is at a much higher level dose of the bisphosphonate, and a much lower dose is highly likely to be effective. But nonetheless, it exemplifies the fact that as soon as a patient with M1 disease presents and is treated, if you don't use a bone protecting agent, you roughly double his risk of a pathological fracture or an osteoporotic fracture later down the line. And that is at the 5-year incidence of fracture-related hospitalization for M0 and M1. And that's on very accurate data linked in through trials. And so with this imaging analysis tool, what we can do is we can look at other things which are critically important to men who are often elderly, who are often comorbid, and we can try to work out what's happening in a trial and cross-correlate that with what's happening out in the real world when a patient of, let's say, 75 or even 80 presents with primary presenting metastatic disease. So we can look at loss of muscle mass, and we can look at that at baseline, 2 years and 5 years, and see what the effect of ADT is, what the effect of radiation is, what the effect of adding an ARTA, an androgen receptor targeted agent, to that regimen. Because there's no doubt that when you start looking at a patient like this who has a significant muscle mass loss over 5 years, and we can map that and digitize it and put numbers on it, and you can see that this individual patient's loss of muscle, and that's without looking at the quality of muscle, which we can also do, has actually diminished quite substantially and may well contribute to the falls and fractures which we see in this group of patients. And you can see the level of sophistication that's now available using just a standard CT, which is available in any department in most urology departments around the world. Another thing that we're looking at carefully is the cardiovascular effects of androgen receptor signaling inhibitors in the treatment of advanced prostate cancer using the same techniques. And what we've done is a meta-analysis initially to validate some of this, pulling together all the records from trials with ARTA therapies in 24 studies around the world, and looking at the grade 3 cardiovascular events. And that's quite interesting when you start to look at this, both in the non-metastatic hormone sensitive, the metastatic hormone sensitive, and the CRPC settings. Because looking at reporting of CV adverse events in most eligible trials, there are clear differences when you start to add in any of the ARTA-based therapies. This paper's just been accepted by JAMA Oncology. And what's interesting, if you look at the left of this graph, of this slide here, with an androgen receptor signaling approach, and without that, you can see that the incidence of cardiovascular toxicity goes up quite substantially as soon as you add in an ARTA, whether it's abiraterone or any of the amides. And looking at the secondary outcomes, particularly focusing on the grade 3 events such as acute coronary syndrome, cardiovascular or CVA, and cardiovascular death, you can see that they're at a relatively lower level, but they are roughly doubled every time you add in an androgen receptor signaling intervention. And that's an important consideration. So what are we doing to look at that? You can see that the event rate is roughly doubled, and we can now measure this with STAMPEDE-based imaging data, looking at routinely collected healthcare and predictors using imaging biomarkers, particularly things such as abdominal aortic calcification. We know that that measurement in a sophisticated algorithmic AI approach will outperform something like the Framingham Score Index and predict adverse CV outcomes. And this is essentially what is done with the images from STAMPEDE. Currently we're on with this, looking at the staging CT scan with an L3 level and the coronal imaging, which quantifies the aortic calcification, maps that out against the cardiovascular risk profile. And we can then link that to our hospital episode statistics to find out exactly who's had acute coronary syndrome, death from a coronary infarct, CVA, and so on, in a much more accurate way than is otherwise picked up in some of the trial report forms. So,
Noel, you have 1 minute, 2 minutes left.
Okay, last two slides.
Thank you.
So what we have now is the next phase of STAMPEDE, which will run for the next 10 to 15 years. This is STAMPEDE Comparison X, focusing specifically on the oligometastatic question, which has not yet been answered, randomizing to standard of care versus standard of care and SABR, with a sub-stratification for DDR and DDR positive and negative. And we have STAMPEDE Comparison P, which is looking at PSMA lutetium with or without PARP inhibition for DDR negative and positive patients. So this is going to run and run. I'm pleased to say we have a lot more to give, new data, and a lot of translational data emerging from our considerable resources linked to healthcare from public health systems. Thanks very much.
Thank you, Noel. Great talk, great talk. So let's jump to parity issue is one of the biggest issues today in clinical research and also outside of clinical research. So he is in charge of a very, very important topic, and I'm sure that you will deal it at the best. So, Shilpa, we are eager to hear from you.
Thank you, Andrea, again for inviting me to this amazing meeting. And this is a tough topic. Creating societies and trying to transcend the borders. I don't have any relevant disclosures for this talk. In the current state of affairs, disparities in GU cancers and outcomes within countries exist globally, not just within countries, but global disparities. And our desired state is to improve survival of patients with GU cancers worldwide, not just in select few countries like the US and European countries. And the gap would be met by removing barriers of access and disparity globally and identifying a path forward tailored to each country's needs and resources. So the 5 key social determinants of health, or SDOH as it is called, are broken into these categories of economic status of patients, which would be poverty, unemployment, food insecurity, housing, stability, which are basic needs, which need to be met before patients can actually go see a doctor. Education, how educated patients are, what is their health literacy, how much they understand, how much are they willing to go for getting treatment. Healthcare access, whether they live in a rural or an urban area, which country they live in, what kind of insurance they have, and all these factors are built in. Environment, which is again access to the public policies, housing, and is there other major issues they are dealing with, like crime, violence, and now, unfortunately, we also have situations like ongoing wars in the world, which is like a basic call for survival. And social context with civic participation, discrimination, etc. And we need to understand that equality is not the same as equity. Equality means providing everybody with the same resources, no matter where you are in the world or what state you are in, and expecting for the best outcome to happen. But it may not be suited. For example, a patient who is special needs would not really benefit from providing them with a bike. So that's what this cartoon demonstrates, that we need to provide equity that is tailor everything to each patient's individual needs wherever they are. And in the social determinants of health, achieving health equity could be providing basic needs like education, jobs, providing health literacy, food security, transportation, social work, outreach. Now I know in the UK, Dr. Nick James does the MAN van where they go and do prostate cancer screenings. In the US, in some areas, there are all these barbershops initiatives, and all those things can help achieve health equity. I came across this interesting cancer projection trends for Europe in 2040. And as you can see here, in 2020, 62% of all new cancer cases occurred in patients who were 65 years or older, and 3/4 were all cancer deaths in this age group. And this baby booming population in 2040 is only going to increase. More patients are going to be in the aging population, and there'll be even more disparities between men and women, which we are dealing with now. And talking about the burden of the problem in GU cancers, worldwide, kidney, bladder, and prostate cancers are the most common GU cancers, with almost 2 million new cases worldwide. And in the US, GU cancers represent more than 400,000 new diagnoses annually, and more than 20% of all cancer diagnoses. Prostate and male bladder cancers represent around 50,000 deaths annually, which is 15% of all male cancer deaths. And there's humbling mortality rates based on race, ethnicity, gender, and zip codes. This is in the advanced country like the US. And these are the estimated number of incident cases and deaths of bladder cancer in males in all age groups across the world. And if we look at the highly populated countries, now India is one of the most highly populated countries, we see that it could be that bladder cancer is not, there's not enough diagnosis, so we see that incidence low, but we do see that deaths are still fairly high. In China, we know there's a lot of environmental exposure, and rates of death are also very high. And in the US, we see that there's a discrepancy between the whites and the blacks. Bladder cancer is more common in white males and also common in men compared to women. And the mortality rates have been declining for black men, Primarily, it's possible because of the decreased risk of smoking due to several interventions, and not as much in the white men. And in prostate cancer, incidence is dramatically highest amongst non-Hispanic black men. As we can see here, the recommended screening guidelines affect the diagnosis and screening, but the non-Hispanic black men are at highest risk in the US. And also because of the screening guidelines changes, there's been a stage shift in prostate cancer over the last several decades, and more men are now being diagnosed with advanced stage. For example, there was a 6% annual increase in advanced stage diagnosis since 2011. Now coming to kidney cancer in males, this is again looking at all these countries. It's also more common in China, followed by US, and then other countries. And these are the kidney cancer age-specific mortality rates by race and ethnicity. As we can see, a lot of discrepancies exist, and this is based primarily in the US. Testicular cancer also, Hispanic men had a statistically significant increase in overall cancer-specific mortality, and this is because of late-stage diagnoses, lack of primary care, lower socioeconomic status, or poor health literacy amongst Hispanic patients. And this is really ironic because this is a curative disease, one of the only curative cancers in solid tumors. And these are some of the statistics for testicular cancer for all ages. And because the chemotherapy is widely available globally, we see that deaths are still lower than other cancers, but still we can do better. Now, how can we address global disparities in access to cancer therapies? This slide outlines how different regions in the world may be affected and what we can do. For example, in the US, we have multiple drug approvals in the same indication, but still there are a lot of barriers, which could be due to high price of drugs, insurance issues, patients not being referred to medical oncologists, or other cost barriers or transportation barriers or zip codes where patients are in. And in South America, the high price of drugs, same as in Asia, especially countries like India, where a lot of clinical trials never make appearance and patients have to pay out of pocket, which really costs them a fortune. And same for Africa. And so if we really look at the rest of the world, there are the basic access issues. But in the US, despite abundance of resources and availability of drugs, we still suffer from attrition in the US. And this slide is another eye-opening slide to show how much health expenditure per capita occurs in the US compared to the rest of the world. The blue areas are the dark blue, it's all US, and rest is all rest of the world, including Europe. There's not so much health expenditure as we see in the US, and still we'll see that there's lack of access within the US. And Dr. Agarwal has done some really great work, and when I was preparing this talk, I came across two substantial bodies of work done by his group. For example, in the initiation of frontline treatment following metastatic castrate-sensitive prostate cancer diagnosis, we see that less than 50% of patients actually get a novel hormonal therapy or chemotherapy. And this is when we have multiple trials showing overall survival benefit with these agents over the last many, many years. And we heard from Dr. Agarwal and Dr. Bigotti today about how much progress has been made and led to drug approvals. But this is still a dismal state of affairs, and there can be various factors. Many times they're not seeing a medical oncologist, or urologists are not offering it, or they're in the community, or lack of access, social literacy, etc. And then on your right, you see the patient age and frontline metastatic CSPC treatment over time. And in 2019, which is just a few years ago, only 52% patients received only ADT for metastatic castrate-sensitive prostate cancer. And only about 7% patients received ADT and docetaxel. 22% patients received a novel hormonal therapy. And this speaks for the fact that it's not just having the drugs available, there's a lot more that needs to be done so every patient can be treated adequately with life-prolonging therapies. And this work again from Dr. Agarwal's group about bladder cancer utilization of systemic therapy, and we heard today from Dr. Necki how much progress has been made with survival improving therapies in bladder cancer. And despite that, when you see here, just a few years ago when this was reported, the high attrition rates, hardly 48% patients get first-line therapy in today's age in a country like US, and very few patients, less than 20%, make it to second line or beyond. Now we'll talk about those were some of the system issues and what are the host-related factors which can lead to disparity in cancer outcomes. Genetic mutations is one. If we look at the field of prostate cancer, so much advancement has been made with PARP inhibitors, PARP inhibitor combinations, so much work led by Dr. Agarwal here. So this also places the patient in that situation where if they are not getting the genetic testing done, we'll never know if they have a tumor harboring these mutations or alterations, and they will never be offered treatment. So if we don't look, we will not find. So that is one problem. I think even in the US, only about 30% patients get genetic testing, even though it is part of all the national guidelines. And secondly, for these mutations, for patients who don't have these in their tumors, they cannot get these therapies. So that's another way of looking at that. Despite on your right, we see all these life-prolonging therapies which are approved in the US. Still, the testing pace is lagging greatly. And like Dr. Necki mentioned earlier today about the field growing targeting FGFR in urothelial cancer, in non-muscle invasive field, we've seen from Dr. Laureate significant advances with FGFR inhibitor, higher incidence of FGFR alterations, and in metastatic disease, again, Dr. Laureate led the TOR trial. We saw the phase 3 confirmatory trials presented at ASCO this year. And here you will see that erdafitinib prolongs survival significantly, but again, testing in bladder cancer patients is also subpar. Not everybody gets tested, and they miss out on these opportunities. And also, if you look at the demographics and disease characteristics, there were 0 black patients, 0 Hispanic patients. So we really need to do better with these trials, and the burden is upon us and the pharma companies to have an outreach globally and not just in a select few countries. And also, interestingly, patients with or without obesity also have different outcomes with immune checkpoint blockade. In the past, we thought that obesity alters the immune system and creates a poor response to immunotherapy, but emerging evidence has shown that obese patients actually respond much better to immunotherapy. As we can see here in the green arrows, both for bladder and kidney cancer, immunotherapy fared better in patients who were at a high BMI. And in our own institutional work, we have shown significant overall survival improvement. Patients who had high BMI and received immunotherapy. We'll present that work at ASCO GU. But this is an interesting finding, and it speaks to the fact that if patients have the health literacy and access to have a healthy lifestyle, good nutrition, access to healthy food, they might not be obese, or they might obesity is still bad, but that would still prevent other issues. So I know there's a lot of industry partners Andrea has invited here, and I think it is important to partner with them to discuss how we can tackle gaps in drug access. Just recently, I was in India, and it was really sad to see that there's absolutely no trials with immunotherapy in GU cancers. In fact, I lost a couple of my close relatives dealing with cancer, and they could barely afford it. But when we look at the US, the ironic shortage of basic cancer drugs like cisplatin and BCG is only a problem in a country like US, not in the rest of the world. And this is also, I think, really sad. There's no shortage of BCG in any country, even in a country like India where it's made, when we're getting strains from India, from Russia, but because these drugs are so cheap, either it is that it's not a priority for the companies, or there's other bigger drugs that they've moved on to. And then more recently, just this year, we were faced with the shortage of a $15 cancer drug, cisplatin. And we were struggling to ration the use of cisplatin for testicular cancer patients to offer them a cure, and denying other patients with metastatic disease, which again, rest of the world did not face this problem. And another important thing that we need to see is like, how was the immunotherapy dosing decided in the trials? While maximum tolerated dose was sought in early phase trials, just like chemotherapy, the phase 3 trials evaluated much higher dose for both approval and marketing. For example, in kidney cancer, the initial phase 2 study showed similar overall survival using 0.3, 2, and 10 mg per kilogram of nivolumab every 3 weeks. But interestingly, in the phase 3 trial, the 3 mg per kilogram dose was chosen for every 2 weeks, which is 15 times the lowest effective dose. Not only it can be more toxic, but also financially it can be very burdensome. And this was really an important editorial by Dr. Ian Tannick in Annals of Oncology last year, where he explored all these different immunotherapies. For example, for pembrolizumab, across solid tumors, it was seen that the PD-1 receptor occupies at a dose of 1 or more mg per kilogram for at least 21 days, but the phase 3 trials used 2 mg per kilogram. And most of these trials did not have any stop date of immunotherapy, and only recently people have started talking about stopping at 2 years. And for atezolizumab, again, early trials showed activity at 1 mg per kilogram, but phase 3 trials used 1200 milligram flat dose. Again, the rationale is not clear. So clearly we are using the drug with no rationale. And this is really a great study that came out of Tata Memorial last year, where they were very creative. In head and neck cancer, they used low-dose immunotherapy, added it to targeted therapy and chemotherapy, and they saw really improvement in outcomes. And the necessity was for them to afford this for the Indian population. And so this is doable, and I wish we were doing more of such trials where we are de-intensifying treatments and not necessarily over-intensifying. Also want to highlight this editorial we wrote a couple of years ago. For disparities in drug pricing, in the UK, the NICE rejected the use of pembrolizumab in platinum refractory urothelial cancer, even though that is the only phase 3 trial showing survival benefit, because of the cost. They had atezolizumab approved, and they wanted pembrolizumab dose to be lower for them to meet their standards of quality associated quali years, which they do like financially if it is feasible for the lifetime of a patient. And they did not approve it, and the hope was that the cost would go down, but Merck decided not to decrease the cost, and only atezolizumab is available in the UK. But at least they took a stand against this. And also, I want to highlight here, if you look at the cost of pembrolizumab in the US, it's $5,580 per 100 grams, and in the UK it is $2630 pounds per 100 milligrams. 100 milligrams. Atezolizumab costs over $10,000 for 1,200 milligrams in the US, and the same drug costs 3,800 euros in UK. So this is clearly a big disparity which is driven by the industry, and we need better policies for this. And talking about the rest of the world, the big question is we have all these life-prolonging therapies, pembrolizumab, erdafitinib, enfortumab vedotin, sacituzumab govitecan. We don't know if it is life-prolonging or not, but it is an effective therapy. And now more recently, we saw Dr. Necki's presentation, the standing ovation that enfortumab and pembro received. But the big question is, will that only be available in the US and selected countries in the UK and Canada, or will the rest of the world will ever see these drugs? And the unit cost for pembro, as I said before, is around $5,000. For erdafitinib, a monthly supply costs $25,000, and a cost per cycle rest of the world, you know, I don't know how people can afford it if it's not an insurance-driven world. Even in the US, a lot of patients can't afford this despite having insurance. Enfortumab vedotin costs $3,500 per 30 milligram vial. So for a 1-month cycle, it'll cost $31,000. Sacituzumab govitecan, again, over $2,000 per vial, which means $17,000 per 3-week cycle. And this really becomes a big problem in countries outside of the developed countries. Also highlighting the number of clinical trials in the world, this was a nice slide presented by Fabio Schulz at ESMO. If you look at this graph, you'll see how many trials the rest of the world has, you know, barely in thousands compared to in the US and other developed countries. So we do need more alternative options and Renotorch-like studies in rest of the world. And this was really a great study we saw at ESMO because lack of access to the standard immunotherapies exists in the rest of the world. The Chinese developed their own immunotherapy. As you can see here in the Renotorch, the study was similar to the axitinib pembro versus sunitinib. They only used intermediate and high-risk group patients, and they demonstrated overall survival benefit with their own homegrown immunotherapy and axitinib compared to sunitinib, and this will become a standard of care based on a phase 3 trial in China, and probably that will expand access to the rest of the world because pembrolizumab is clearly not made it to the rest of the world. And I want to shout out here for the cancer moonshot, which is really a great vision, but the ground shot, we need to solve that problem first and take steps towards addressing disparities before we can really think of cancer moonshot, at least in the US and rest of the world. And addressing disparities is a key problem. So what are some of the strategies to close the gap? We need to make health equity a strategic priority across all levels of social determinants of health and learn and improve. So we saw the excellent session with the patient advocates for the IRCCS today, International Kidney Cancer, and we need to have partnerships, we need to involve more people at the grassroots level, go do outreach. We need the policies for effective prevention, early detection and outreach programs, policies to tackle environmental, occupational exposures, smoking cut down, social support for aging population. Even in a developed country like the US, many patients don't come for treatment because they don't have the support to travel or it's too costly, especially for clinical trials, the frequent visits, they just refuse. We need to have a better trial access, and global regulatory authorities need to partner to push industry for fair drug pricing and access globally. And there are several efforts being made. All is not doom and gloom. For example, Dr. Necki worked with this group to come up with an urgent call of action for disparities and access to novel therapies. In Europe, there's been a creation of European Cancer Inequalities Registry. ASCO and WHO are uniting to launch Global Quality Initiative in cancer care. And just recently, there was a joint press release on the launch of EU and US Health Task Force. And not to mention the Global Society of Rare Geotumors, led by my dear friends Phil and Andrea, and International Bladder Cancer Group, led by Dr. Kamat, who I was replacing earlier, will also, the goal is, again, to reach the world and not just 1 or 2 countries. That is my last slide. Thank you.
Thank you, Shil.